conducted bilateral TKR in Kolkata-based female on last week of the August this year. Patients unfortunately developed a cardiac event after discharge, and for the same she underwent PTCA with stenting elsewhere. Very high dose of thrombolytic agent as well as anticoagulant was given. She came to us about 3 weeks after the surgery with complaining of pain, swelling, intermittent fever. On examination, her left knee having a healed anterior midline scar with local raise of temperature and mild effusions. Her lab report shows the hemoglobin was 12.1, total count 8,600 with raised CRP 63. These are her clinical pictures and post-op X-rays. On aspiration, the 3 cc of reddish turbid fluid was aspirated. It shows very high content of protein. Count was 22,200 with more than 90% are polymorphs. So all pictures suggestive of acute post-operative infections. So we plan for the DAIR, debridement, antibiotics, and these are our theater picture. We use the similar setups, but different or separate setup. Once we put the incision, we aspirate the joints and send the media immediately for cultures. We use Bactec media, PET plus, as well as myco media. PET plus will give us a culture for both anaerobic and aerobic bacteria. After finishing this culture part, we give the antibiotics. And joint, there is no any free fluid in the joints, but joint was inflamed. After medial releasing, we check the stability and medial collateral competency, removal of the thickened fibrous tissue from the infrapatellar area. Now cleaning the medial gutter by removing the hypertrophied and inflamed synovial tissue. The crux in the success of DAIR procedures is about the debridement. The good debridement will always give the successful results. From the lateral gutter as well. So we are removing the suprapatellar pouch, synovial tissue from the suprapatellar pouch as well as from the medial and lateral gutter. We do the thorough curettage for the remnants of the synovial tissue from the surface around the periprosthetic area of the femur. We do the curettage over the medial collateral ligament, around the collateral ligament and medial femoral condyle, as well as lateral femoral condyle. Remove all the soft tissue from the intercondylar notch by Ronger. Remove the synovial tissue from the medial compartment and around the tibia. By this way, we check the integrity of the cement as well. Once this part is over, we remove the modular insert. Now we have a better access of the lateral compartment as well as posterior compartment. We remove the synovial tissue from the lateral part, coagulate the genicular vessels. Now removal of the soft tissue from the posterior compartment. All devitalized tissue must be removed. And whatever attached synovial tissue, devitalized synovial tissue, we have to remove it with scoop or curette. Hard curettage over the posterior capsule as well as in the intercondylar notch area. we should go compartment-wise, so we have to be a thorough and meticulous debridement possible. Now we go for the anterior compartment. Around the patella, there is always a hard menisci-like structures around the patella. We have to remove that part, as well as whatever the synovial tissue beneath the quadriceps tendons as well as patellar tendon, we have to remove it. So two instruments, one is the ronger and second one is the scoop or curettage. That is must. After thorough wash, mechanical debridement will give 3 liters of wash. That is followed by irrigation with diluted betadine iodine and hydrogen peroxide solution. We pack the wound for at least 10 minutes. So I better say it's a time for 10-minute coffee break. After package, we have to pack the wound. Again wash with 3 liters of saline, and that is followed by eradication of the biofilm with diluted 5% acetic acid solution. We again pack the wound for 10 minutes with diluted acetic acid solutions, soaked gauze piece. Irrigate the joint again with 3 liters of saline. So total 9 liters of saline we usually use for irrigation of the wound, and about 400 liters plus for dilution of the betadine iodine and acetic acid. Now change the drape, change the gloves, recheck the stability by putting trial insert. Once we confirm the stability, we will put the final implantations, relook the debridement part, and finally we put the vancomycin intra-articularly over the implants, exposed part of the implants, to remove the biofilm whatever there, and to have a very high concentration of vancomycin intra-articularly. Thank you very much.